Okay, so this video is going to wrap up the heart chapter of the circulatory system. We'll start by talking about regulation of heart rate. Remember that heart rate originates in the autorhythmic fibers directly within the sinoatrial node, the conduction through to the AV node, and then down through the conduction fibers in the ventricular myocardium. And we made a very big point about saying that we don't need the central nervous system to have those autorhythmic fibers fire. But I don't want to leave anyone with the impression that the central nervous system doesn't play a role in the regulation of the heart rate. So, because it absolutely does. And nervous system control of or regulation of heart rate comes predominantly from the cardiac center. That cardiac center is located in the medulla oblongata. We're going to see both sympathetic and parasympathetic input. We've got baroreceptors in a couple of different places. Remember, baroreceptors are pressure receptors. We've got them located in the arch of the aorta and the carotid arteries. They're going to detect blood pressure changes, and they're going to send information into that cardiovascular center to help with the influence. Hormonal influences, epinephrine, norepinephrine, thyroxine, so those catecholamines and the thyroxine hormones. We can have ion changes that'll produce hormonal influences, so things like sodium, calcium, potassium levels. Certainly hormonal influences can change with age, gender, body temperature, physical fitness, those sorts of things. So certainly an active role. This is a nice diagram from the publisher that talks about input into the cardiovascular center and then the output towards the heart, and how those inputs will influence what happens on the output. So just to reiterate, we're not relying on the autonomic nervous system for basic rhythm. We have abundant sympathetic and parasympathetic innervation that can alter the rate and the force of contractions, and that role of the autonomic system is really to regulate changes in blood flow, blood pressure, blood volume. We need to maintain the cardiac output to the point that we want to provide for all organs at all times. So this is really about homeostasis again. Remember here, our cardiovascular center being in the medulla oblongata. It's going to have some cell bodies of neurons that are going to make up what's called the cardio accelerator center. They're going to have sensory information coming in from baroreceptors in the carotid body and the aortic arch. We're going to relay information about blood pressure, blood flow to that cardio acceleratory center. We're going to have sympathetic fibers that are going to pass through the spinal cord and enter that sympathetic ganglion. Remember, the sympathetic ganglion is located near the thoracic region on the spinal column. They're going to leave that sympathetic ganglion, enter into the heart. We're also going to, in that medulla, we're going to see some cell bodies of neurons that are going to make up the cardioinhibitory center. So that same sensory information coming in from all of those peripheral baroreceptors is going to go into this cardioinhibitory center. And when we stimulate that inhibitory center, what we're going to see are parasympathetic fibers in cranial nerve 10, which we'll call as vagus. And then we're going to release acetylcholine. We're going to see a decrease in heart rate and strength of contraction. The left and right vagal nerves are going to continue onto the abdomen and innervate structures there. So we really have a very complete autonomic fine-tuning that happens, and all of it again is to just really, the goal is homeostasis. With that said, there are some risk factors, there are disease factors that I want you to be aware of, and we have those that we can work on, that we can change to a certain degree, if not eliminate entirely, and we have those that are just genetics and luck. So risk factors in heart disease that we can work on, or we can change, or we can medicate, or we can do something to potentially alter are things like high blood cholesterol, elevated blood pressure. We've proven through decades of study that lack of exercise, obesity, cigarette smoking, all of those sorts of things will increase the risk for heart disease. And then there are other things that, we don't really have any control over. Things like a genetic predisposition to diabetes mellitus, or just a general predisposition to hypertension or cardiovascular disease. Gender is not something we control. Historically, we have seen males have a higher risk factor than females. That is not so much the case. Those numbers have pretty much leveled out. I think we're really at a 51-49 sort of shift as far as percentages anymore. We can see increased fibrinogen levels in circulation. That will give us an increased risk, just because when that fibrinogen, remember, is converted into fibrin, then we're going to see microclots. Left ventricular hypertrophy being an increased muscle size, that can give us risks for cardiac disease, and there's nothing any of us are going to do about those. Blood cholesterol, we used to talk about normal values, and we really don't. And even your primary care physician won't talk so much about those normal values anymore. More about other risk factors, other things that are indicators, and anybody typically anymore over the age of 45, they want to put on a statin to help control that cholesterol level. So as blood cholesterol increases, the chance for developing a heart disease due to a fatty plaque formation increases as well. We get our cholesterol from two sources. Either we ingest it or it forms within the liver. We talk about different lipoprotein terms or forms. We talk about LDLs, HDLs, and VLDLs. Historically, we've talked about the bad cholesterol being low density lipoproteins. These guys are the ones that typically associate with fatty plaque formation. The high density lipoproteins we've called historically the good cholesterol, the HDLs. They actually act like dump trucks, going along and removing excess cholesterol from circulation. So we love those HDLs to be high because they're out there scooping up any excess cholesterol. And then the really, really bad actors are the VLDLs, the very low density lipoproteins. And these guys are very notorious for fatty plaque formation. I threw this in from the book, just this developmental anatomy, and how we see this cardiogenic area form. We get a venous end of the heart at about 20 days. We get fusion of endocardial tubes in the primitive heart. So we go from this small region into two long strands. Now we're seeing bridging across. We're actually going to see those areas fuse entirely by about 22 days in the embryonic cycle. We'll start to get a bulbous cordis formation here and some primitive ventricle formation by day 23. And then day 24 we're starting to, and then here by day 28 we're actually getting what is going to look very similar to a fetal heart or even an adult heart. So developmental comes from the mesoderm before the end of the 3rd week of gestation. We're going to hear that first heartbeat, or be able to detect that first heartbeat right around 6 to 7 weeks. And I don't typically test this, but I think it's kind of fascinating to look at the developmental portion, and this will become important a little bit when we talk at the end of the semester and we talk about blood flow within that fetal heart. And then finally, I want you to take a look at some homeostatic imbalances. So look, pull your text, go out and research a little bit, know some potential causes and treatments for coronary artery disease. For arrhythmias, there's 3 categories. I want you to know the names and definitions. and then congenital heart defects, what it means to have a congenital heart defect. We'll talk a bit about those more at the end of the semester as well, and then just a basic potential cause for congestive heart failure. And I believe, yep, that's our last slide. So that wraps up the heart chapter of the circulatory system.